Okay, good morning, everyone. Trying to be socially distanced and doing a case conference together. It is my pleasure to first, I would like to introduce a special guest, Dr. Ria Chu, and perhaps she can show herself for a second in the panel. Dr. Chu, are you with us?
Yep, good morning. Thank you for inviting me.
Wonderful. So Dr. Chu is professor of allergy and immunology, and we met over this case many years ago. So I wanted to invite her to ask some input from her. So first off, some of you might be wondering, it's usually the Dolinski Pew conference. What happened to Dr. Pew? And I want you to know that I've gotten special permission from Dr. Pew to go ahead with a conference with Dr. Hang, our critical care fellow. And I want to assure you that I'm not cheating on Dr. Pew. We're still a case conference couple. So, Dr. Hang, would you like to get us started with this patient?
Absolutely. So I think you just have to.
Did mute me.
All right. So our patient is a 77 kilogram, 54-year-old female who presented for a total abdominal hysterectomy for a presumed ovarian mass. Her past medical history really only included hypertension, which was well controlled. She really didn't have any significant surgical history prior to this procedure. For allergies, she was listed as having a penicillin allergy as a child. She also noted that her father had a penicillin allergy as well. In regards to her home meds, very minimal. She is on lisinopril, 2.5 milligrams daily, which she takes religiously. Her vitamin D also she takes. On exam in the pre-op area, you know that everything is unremarkable. For the induction, the patient received 200 milligrams of propofol, 100 mics of fentanyl, 8 milligrams of vecuronium, 200 cc's of plasmite during the course of induction. Following induction, she also received 2 grams of sulfoxetine for antibiotic prophylaxis. In regards to maintenance, you had turned on some sevoflurane in oxygen and air. Things are looking good. You're starting to do some charting. 20 minutes post-induction, you notice that the blood pressure had decreased from 120 over 70 to suddenly 60s over 40s. You also note that the heart rate is now 48, which it was around in the 80s. You quickly look over to your ventilator, and you notice that the end tidal is 22, which is low. So let us develop a differential diagnosis, and let us ask the CA1s specifically for this task. And as you guys are naming some potential diagnoses for this hypotension extraoperatively, we will write it down. So you guys will see it as you name it. So let's go ahead. CA1, go ahead and start naming off some differential diagnoses.
Maybe hypotension just from the volatile anesthetic itself.
Good. Keep it coming.
Same ones I haven't seen.
I don't know if they insufflated potentially the hypotension bradycardia from insufflation.
It's an open case.
It is an open case, so
We never made an incision.
and this is pre-incision.
Hypovolemia.
Good. Back to the basics. Very good.
I'm going to go out on a limb and say anaphylaxis.
Okay, good.
What's up?
Pulmonary embolism.
Excellent. You guys are just getting them all. There's a couple more though, so keep them coming. Yeah, remember I said that she takes her,
Myocardial ischemia.
good myocardial ischemia, very good. Infarction. Dr. Dolinski had put up lisinopril there, and as I mentioned before, she had taken her lisinopril religiously, so maybe she took it preoperatively, even though she probably was told to hold it.
Hey, Dustin, I'm going to say anaphylactoid reaction.
All right, anaphylactoid. And what is the difference between anaphylaxis versus anaphylactoid? Anyone can answer this, really.
They have pretty similar clinical physiology manifestations, but anaphylaxis is a true immediate IgE mediated response, whereas anaphylactoid is usually not. So it is kind of encompassing a couple different ones.
Anaphylactoid is, yeah, like Andy said, is direct stimulation of mast cells from non-IgE versus IgE-mediated anaphylaxis.
Very good. And non-IgE mediated. So, what's an example of a trigger for that? So, what system sometimes is responsible for anaphylactoid reaction?
What I mean, God.
What was that?
A trigger can be things like protamine.
Okay. And I was thinking specifically about complements. So C3A, C5A, they're considered anaphylactoxins, and they can cause direct release of histamine in response to these fragments. So the complement system plays a large role in anaphylactoid reactions as well. That's not to say that they don't play a role in anaphylaxis, but they also play a role in anaphylactoid. And as Annie mentioned, the clinical manifestations sometimes are indistinguishable.
And Dr. Chu, would you like to make a comment about that?
Sure. I think that you guys actually really hit it on the head, that anaphylaxis is considered the IgE mediated, anaphylactoid is the non-IgE mediated or direct mast cell mediator release. However, nowadays, because of, just as someone said, since the clinical symptomatology and reaction is very similar and you would treat it the same, I think actually the World Allergy Organization and World Health Organization have now really called it just anaphylaxis, and they're not really distinguishing between anaphylactoid anymore.
Thank you for that. So here we have, all of these things pretty much are associated typically with hypotension and a tachycardia. And note that this lady had she had a bradycardia, she had a hypotension noted, and she also had a low end tidal CO2. So given those things, we have to think about, we can perhaps explain why someone's blood pressure or heart rate, I should say, may not increase due to propofol on induction, that you might have a ablation or inhibition, or you have less sensitivity to your baroreceptors. So we could maybe explain that, but we don't really see bradycardia with induction of propofol. And of all these different conditions, perhaps only the myocardial infarction, if it is a posterior inferior myocardial infarction, may you see bradycardia. So we came up with a good differential, but since we have some AA students that are pretty junior, we have SRNA students, and we have some junior interns as well as residents, we might think that our job in the operating room is just to restore things to normal. So we could increase the ventilatory set or decrease the ventilatory setting to allow the CO2 to come up. We can, if we're really smart, give a medication that will not only increase the blood pressure, but also the heart rate. But we might be making some inadvertent mistakes if that's what we do, and that's all we do in the operating room, because sometimes there can be some misleading or mistakes that could be occurring because of that. So, for example, if you are an intern and you have a patient that's hyponatremic and you restore that sodium very quickly back to normal, you can result into something called pontine myelinolysis. That is a fancy word for brainstem damage. And sometimes there's a physiologic advantage or benefit to allowing the blood pressure to be a little bit low. And we see that in the trauma room, where we don't want to restore somebody's blood pressure back up to their normal or within 20% of the mean of their blood pressure, because again, we can decrease bleeding by keeping the blood pressure closer to a systolic of 90. And finally, as a novice, if we might not be addressing the underlying problem. So, for example, we can certainly give blood products and the like to somebody that's bleeding, but if we don't treat the underlying cause, that patient will still die. So let's think about, normally we have something called the baroreceptor reflex. And this is really a quick board review of what the baroreceptor reflex is. And what you can see is that normally we have the baroreceptors that are located in the carotid sinus and the aortic arch, and you have tonic firing of the baroreceptors, and it keeps our blood pressure in the normal range. But if we have an increase in our blood pressure, the baroreceptors increase their firing, which leads to an impulses back to the brain, leading to a decrease in sympathetic output and causing vasodilation, and also allowing the efferent reflex back to the SA node, causing a bradycardia and restoring the blood pressure back to normal. So that's how we get that reflex bradycardia when you see hypertension. Conversely, when the blood pressure is on the low side, the baroreceptors decrease their firing, and that leads to an inhibition of an uninhibition. Dr. Spofford asked if she could annotate. Dr. Spofford, did you want to make a comment? Okay. So that means that when we have a bradycardia, we, let's see. Oh boy, I'm sure what I did now. I shouldn't have done that. I gave her, granted her permission, and now I have a problem. Yeah, well, okay. Anyway, so let's go to one thing that we don't always know is that there is a so what happens is sorry, I got a little here. So if we have a decrease in our blood volume, normally, as I stated, we have the baroreceptor reflex that happens. So we decrease our baroreceptor discharge, as I just showed you, and we have an increase in our sympathetic output, increase in arterial tone, and the peripheral vascular resistance increases, all to increase our blood pressure. There's another reflex, however, the basal-gerish reflex, that has an inhibitory aspect, and it is overridden by the baroreceptor. And that has more of an inhibitory effect on the vasomotor center. And because it's inhibited, typically, we have a vasomotor center inhibition, allowing again for sympathetic output that affects the kidneys, leading to an increase in renin release, increase in angiotensin, increase in aldosterone, and increase in ADH, all to help restore blood pressure. However, when there's severe decrease in blood volume, and I have to stress this is a board question that comes up. Nevertheless, you have to be aware that this is actually a theory and it hasn't really been proven. There are chemoreceptors in the heart where if you inject some stringent materials, this will happen. And also it's been shown in animals that a decrease in blood volume of more than say 600 cc's or so will, or in a human 600 cc's of blood loss can lead to this reflex. And we certainly see this in trauma patients. But in this case, when you have a lot of severe decrease in your blood volume, the baroreceptor reflex is overridden, and you have a preferential increase in your cardioinhibitory discharge from the central nervous system. And that's because the thought is that when you have contraction of the ventricle on an empty ventricle, the whole idea is to maybe allow bradycardia to allow filling of that ventricle. So it leads to bradycardia, and because of the concomitant inhibition of sympathetic output, you have a decrease in peripheral vascular resistance and continued hypotension. So the main point here is that when you do see this, and it can, like I said, if you do enough trauma, you'll see this happen. It can be a harbinger of cardiovascular collapse. So, Dr. Hang, you want to continue with the intraoperative course?
All right. So the hypotension intraoperatively is unresponsive to phenylephrine, ephedrine, the usual stuff that you would use. Vasopressin also doesn't seem to be working. Fluids, a very marginal response. However, the hypotension, it does respond to multiple doses, multiple small doses of epinephrine. Subsequently, she required an epinephrine infusion to be started to maintain a mean arterial pressure of greater than 65. At this point in the case, the surgery is aborted. She is transferred to the SICU, intubated on that epinephrine infusion that was started intraoperatively, as well as dopamine and heparin. So we can probably agree at this time that the patient has a presumable diagnosis of anaphylaxis. And so I will ask the CA2s this time, not CA1, CA2s. So pay attention. How might you make the presumptive diagnosis of anaphylaxis intraoperatively? What would you get to help you do that?
You can send a tryptase.
Good. The tryptase. So tell me a little bit more about why you would get a tryptase. Stuart? Were you saying something?
I'm trying to. Can you hear me?
Yes, I can hear you now.
Sorry. So tryptase is found in mast cells, and when they're degranulated, either from an anaphylactoid reaction or an anaphylaxis reaction, I guess it's all anaphylaxis now, then that would be a marker, kind of like a troponin is a marker for cardiac injury. It would be a marker for mast cell degranulation associated with anaphylaxis.
Good. Okay. And when?
But Dustin, I would argue that if you're in an emergent situation in the OR, that's not necessarily going to help you diagnose. It's going to help you confirm your suspected diagnosis, because it takes a while to come back.
Sure.
So if you're thinking, this might be anaphylaxis, I'll send a tryptase, and you haven't already addressed the problem, you're going to be up a creek while you're waiting on that pending tryptase. So to diagnose it in the OR, I would do a lot of clinical fact finding.
Sure.
While sending the tryptase.
Yeah, I think that's an excellent point. You have to deal with what's given to you intraoperatively, and you are correct that this tryptase is really for retrospective confirmation of whether or not this was truly an anaphylactic or anaphylactoid reaction. So good. That's an excellent point, Annie. Thank you. My next question is, when when is the most optimal time to get this tryptase?
Between 1 and 3 hours after the invit started.
Okay, and why do you say that, Josh? Josh,
You're trying to get the maximum. That graph you got, that one.
excellent. And Dr. Dolinski here will explain the time course of tryptase.
So basically, this is taken from the World Allergy Organization, and you can see that the times of onset of the tryptase happens somewhere maximally around maybe 2 hours, but you can still see an elevation all the way up to 6 hours. And so it's recommended that even if after surgery, to think about it to get the tryptase level. There's hypotension that seems to be associated with an increase in tryptase release. So tryptase is sort of one of the big markers that this is actually an anaphylactic reaction. Another thing, let me ask Dr. Tu. I want to first of all thank you again for participating in this conference. It's very early for you, I know. Is there anything else we can order intraoperatively to make this diagnosis?
I think exactly what you said. We typically rely on the tryptase, and as one of the residents, I think it was Annie, who very appropriately said, that's to kind of help in confirming the diagnosis. You obviously want to treat them clinically, as you all are talking about. Tryptase, because of the duration, as Dr. Dolinski mentioned from the graph, is the one that would, the mast cell mediator that stays around, quote unquote, the longest. Some people might ask, why don't you do histamine? Histamine is very quickly in the serum and system, and so it goes away too fast that you may not be thinking about it. So tryptase is the one that we typically order, and I think you all will probably be talking about a little bit later. But you can do it even later on after the course of if you decide to have proceed with the surgery or what have you, and then being able to check it even afterwards, just to make sure, kind of from a baseline standpoint, that it does normalize is helpful. However, you can imagine tryptase is not going to be 100% sensitive. And as the other person mentioned, it can take a long time to get the result back. So a normal tryptase does not rule out anaphylaxis. It's just actually helpful to do. And then the idea of repeat checking it, whether it is after 24 hours later, or maybe even after they see the allergist, the idea is that you just want to make sure that that person doesn't have some kind of mast cell disorder, which causes the mast cell mediators to release more, let's say, inappropriately, because there's a higher mast cell burden. So you may want to rule out, again, get that tryptase level to make sure they don't have some kind of a mast cell disorder.
So we call that, she had received at this point propofol, she had received vecuronium, she had received fentanyl, as well as cefoxitin. So the question is, which one of these agents is most likely responsible for anaphylaxis? Anyone want to answer that question? Dr. Smith, Jason.
I think it's most likely the antibiotic. However, I would consider the neuromuscular blocking agent as the other offender.
According to the papers you sent us, it's likely the antibiotic compared to the neuromuscular blocker.
So when you look historically, the best data of perioperative anaphylaxis is actually derived from the French, who have done multi-center French surveys in the beginning in the mid-1980s, actually, and they've continued to the present. And they found, and this is just a sampling from an article, a French article that looked at the time, comparing over time, the time course of what were the most likely mediators. And you can see that neuromuscular blockers sort of were starting to decrease. And in fact, when I was a resident, we were taught, and in the textbooks it said 70% of the time it was a neuromuscular blocker, and it was less likely to be an antibiotic at that time. And latex was also a very common cause of anaphylaxis. And in France at that time, it was considered to be the second largest cause of anaphylaxis. There's very little epidemiologic data from North America. And a study that was published from the Mayo Clinic that reviewed skin test database, they have over a 20-year period, we had only 38 patients to report on. And in their study, they showed that 50% of the time, the patients were found to have an antibiotic as the causative agent. But if we go back to the, again, historically in time, with the responsible agent was usually the neuromuscular blocker. And it depends on what study you read from Europe. Sometimes it was rocuronium, sometimes succinylcholine was the most common cause, but it was almost always a neuromuscular agent that was the cause of the anaphylaxis. So the question comes up sometimes, well, if the neuromuscular blocker were rocuronium or even vecuronium for that matter, and assuming we had Sugammadex back then, would Sugammadex be helpful to, to perhaps abort this and treat immediately by encapsulating that neuromuscular agent? Would that be helpful? That might be something that somebody might think about. What do you guys think about that? Trevor, I see you in the picture.
Likely no,
Yeah,
because they can have a
likely
reaction to
no,
that as well.
Yeah, exactly. That was what I was get the speaker on. But yeah, likely there's a lot of people that have reactions itself to Sugammadex. Theoretically, it sounds good.
And in fact, in the article, it's sort of stressing that maybe one shouldn't be experimenting with that, and there's no direct evidence for that. Although there are some case reports that have documented that they had resolution of the anaphylaxis fairly quickly when Sugammadex was given. But this has not been studied completely, and if you look at those are anecdotal studies. And there is some data from actual laboratory studies that suggest that it wouldn't really be helpful. So we don't know, and that needs to still be sorted out at this point. So Dr. Chu, we note that this patient had a penicillin allergy as a child. Does this mean that cefoxitin would be more likely the culprit?
That's a great question because clinically that comes up a lot regarding the penicillin and cephalosporin cross-reactivity. But really what we are thinking now is that those estimates of the cross-reactivity reactions with cephalosporins and penicillin allergy, it was way overestimated. And, some of the studies even say up to 10 to 20%. And it's felt that a lot of that had to do with the contamination of when they made cephalosporins way back in the 1940s and 50s. So we know that it's much, much less now. The other important thing about this is a penicillin, quote, allergy when they were a child, in really trying to find out more information about the reaction that they had is going to be helpful. Again, this lady is 54, so she might say, my parents told me that I had a reaction, so I've been avoiding it. But the good news is that the longer you go avoiding, quote, the penicillin, really the studies show even 10, if not 20 years past that time frame, they're more likely to have outgrown it, or again, it may never have even been a true allergy to begin with. So you really should feel comfortable giving a cephalosporin, again, depending on the generation and the R1 chains, with someone who has a quote penicillin allergy that's been many, many years ago. I mean, again, something to consider obviously in our differential, but I think most people would feel comfortable with that family, with the penicillin allergy as a child, than giving her the cefoxitin even in the OR.
So also, she did report that her father had an anaphylactic reaction to penicillin. Does that make it more likely that she would react to penicillin?
Also another good question because we get that asked a lot, but a family history of a penicillin anaphylactic reaction is not going to be a direct inherited to the child or the sibling or any other family member. When we ask about atopy, it really is just kind of that condition of being atopic. So allergies and allergic conditions can be inherited, but it's never a direct relationship like that. So Again, it's important in the history, but it doesn't necessarily mean that she's going to be more likely to be penicillin anaphylactic.
And Dr. Chu, if the patient reports that they had a penicillin allergy, but they really can't recall what the reaction was, and you investigate and they don't report anything like anaphylaxis or urticaria, respiratory difficulties, and this did happen as a child, is it safe that they receive a cephalosporin?
Yeah, I think that especially if you talk to the patient and make sure that they're kind of aware that the risks are very low, and if the cefoxitin or the cephalosporin antibiotic is the appropriate one to use in that case preoperatively, I think that it is, you should be able to make or give the patient some reassurance about it. Kind of as I mentioned, because if the person doesn't recall a true anaphylactic reaction or one of the severe cutaneous reactions like Stevens-Johnson's or one of those immunologic but non-IgE mediated kind of reactions, and it has been this many years ago, you discuss with the patient. In my opinion, I think that it would be reasonable to go ahead and give that antibiotic again if that's the appropriate one to use. We are currently doing things with studies looking at kind of low risk individuals and high risk individuals, and maybe even giving the antibiotic in different settings, whether it's in the emergency department. I think in the literature there's been some given in a pre-op clinic as well, under the direction of a provider, of course. And again, in the low risk situations, we are getting much more information that it is safe to be able to give the antibiotic within those parameters.
And one final question: what is the current thought of cross-reactivity of cephalosporins to someone who's had a penicillin allergy?
Yeah, they think that it was way overestimated before, so it really is much, much lower than it was thought before. Again, some of the studies suggest 10 to 20%. They thought it's now related to cross-contamination. So really it's far less than that, maybe in the 2%, 3% or something like that. So again, talking to the patients, making sure that they're aware that was an overestimation. And again, if it's the appropriate antibiotic, I think it's certainly it's very appropriate to go ahead and give that antibiotic.
Great, thank you.
Mm-hmm.
All right. So I'll start off with a rhetorical question. How many of you have seen the penicillin allergy on a patient's chart and the morning of surgery and reflexively reached for the clindamycin without a second thought? It's a rhetorical question because I think most of us have, myself included, many, many times. The truth, however, as Dr. Chu mentions, is that we probably shouldn't be doing that without a thought. And why is that? It's recognized that a penicillin allergy has.
Oh, he's scheduled.
Can someone, Dr. Gonzalez, could you mute?
We're scheduled together, but I don't think I was on the pre-op note, so I wrote the pre-op note for you, and I was like, oh, thanks, man. At least there's that.
Could you mute your phone?
Thank you.
Okay, great. So why is giving thought to penicillin important? It's recognized that a label of penicillin allergy has consequences, both to the economics of healthcare, but also direct patient outcomes. And specific to our specialty, cefazolin is the recommended prophylactic agent against surgical site infections, specifically for the majority of our surgical procedures. And it has been shown in literature that use of non-beta-lactam agents such as clindamycin increases actually the risk of surgical site infections up to about 50%. So the next time you spike that clindamycin bag because a penicillin allergy wasn't really looked into, just remember that you specifically might be subjecting your patient to a surgical site infection quite unnecessarily. In addition, as everyone knows, in terms of antibiotic stewardship, the use of incorrect antibiotics may lead to an increased risk of developing C. diff and multi-drug resistant organisms. So how do you think about the patient with a penicillin allergy? As Dr. Chu had mentioned, based on the history of the patient alone, you can stratify the likelihood of hypersensitivity reaction to penicillin. It's important to note that this is according to the literature. More than 95% of patients labeled as penicillin allergy can actually tolerate antibiotics from this class for really three major reasons. The first being what Dr. Chu had mentioned: 80% of these patients with IgE-mediated penicillin allergies will actually have a waning of that response over the course of 10 years or so, 10 to 20 years. Secondly, most patients with benign rash most likely got that rash from a type 4 cell-mediated hypersensitivity reaction, which may or may not show up again if given penicillin. Third, many patients didn't actually have a hypersensitivity reaction at all, but some other side effect that they labeled as an allergy. So this top chart here, this is from a JAMA Review article in 2019, which I think nicely categorizes the characteristics that would make a patient either low risk, medium risk, or high risk for a subsequent hypersensitivity reaction to penicillin. Briefly, the low risk symptoms and history include non-specific isolated reaction symptoms that really don't have features of IgE involvement. Moderate risk includes rashes that are IgE mediated, just short of anaphylaxis, and high risk includes patients with anaphylaxis and recurrent reactions or reactions to multiple antibiotics. For our purposes, patients that are low risk have a very low risk of a reaction to ANSEF. To add to your clinical toolbox, in an article by Trubiano and colleagues, again in JAMA from this year, they created and validated a clinical tool based off of, again, patient history to assess the likelihood of a positive penicillin allergy. And the mnemonic is PenFast. So that is for patients with pen or penicillin allergy listed. The four factors that are associated with a positive penicillin allergy are F, 5 or fewer years since the reaction; A, for anaphylaxis, angioedema; S, for severe cutaneous adverse reaction like Stevens-Johnson's; and T, for a treatment that was required for this allergic episode. So if you had F, you scored 2 points. If you had either A or S, you scored 2 points. And if you had T, you would score 1 point. And specifically, a score of less than 3, so 1 or 2, had a negative predictive value of over 96%, which is extremely good and enough to exclude severe penicillin allergy. So, Dr. Chu, do you agree with this mnemonic?
Yeah, I think it's a very, very helpful mnemonic because, again, it just kind of reminds us that many people who are labeled as penicillin allergy are not. So getting more history about what the actual reaction was is helpful, because it could be just diarrhea. It could be family history. Again, things that we know are not IgE-mediated symptoms. Again, the timing, if it's greater than 10 years, you feel more comfortable that they have been more likely to either have grown a true IgE-mediated allergy, or again, it wasn't even an IgE-mediated reaction. And then the other kind of symptomatology, again, if it was a severe reaction, if they have the severe cutaneous kind of reaction, or if they remember needing treatment, that's also very, very helpful. Another thing, because this is very timely, I had a patient, a young kid yesterday that I saw in clinic. If you're able to have time to get the history, if the reaction happened on their first course of that antibiotic or any medication, it's less likely to be IgE mediated because you would have needed to have had some kind of prior exposure as well. So yeah, the mnemonic is actually a very good mnemonic.
So
Can I just make a like one little comment quickly, like as an aside? This is Annie. So Dr. Chu, I've worked with you in the past. I was a pediatrician. So when I was in primary care, this was a big thing that came up, particularly for kids that had that label when they would get sick, but also when we knew that they were headed to the OR. And so it's kind of neat because at least in kids, word is out that we're pulling away from this like forever label of penicillin allergy because it does affect our antibiotic choice. But I don't know in the world of internal medicine if it's kind of the same thing, because I see less kids with the attachment had some allergy when they were 12. So I just wonder if there's an opportunity with like pre-op clinic and internal medicine to say, hey, this is our bandwagon and this is what we're left struggling with, and kind of nip it in the bud at the beginning. I don't know, just a thought.
Yeah, no, I think that's a great question. Again, I can't quite address the preoperative clinic thing, but especially from an internal medicine standpoint, if those patients can be delabeled early on, even before they need the surgery, or in our case, another one would be, pregnant women who end up being group B positive, strep, et cetera, it really would be helpful. And from an internist standpoint, the American College of Physicians, ACP, have a campaign called Choose Wisely, and they're trying to do different things to make sure we do things appropriately. And one of the ones we chose as an allergy specialty is definitely antibiotic stewardship, trying to delay patients with penicillin allergy or other reactions inappropriately. So that's an excellent point, Annie.
So going back to our patient, this patient is now rescheduled for surgery 11 days later. And this is when I get involved. And there's a CA1 that calls me at 8 o'clock at night with an elaborate discussion of, what the procedure is and the plan. And as we're about to hang up, about 30 minutes into our discussion, the CA1 says, and oh, by the way, they think she had an anaphylactic reaction last time. So I asked, well, was there a tryptase obtained? Were there any allergy tests performed? And he says no, but she was seen in pre-op clinic, and they said proceed, just avoid that class of neuromuscular blocker. Well, I'm not sure. At that time, I wasn't sure if I would agree with that recommendation. And it turns out that that unfortunately there have been studies that looked at allergic responses to neuromuscular blockers. And there's a cross-reactivity of about 60%. In fact, even when you choose a different selenium agents, there's still a cross-reactivity. But I didn't know that at the time. In fact, this is before smartphones. So this, which just for your knowledge, 2009, those came out. So this is prior to that. So I didn't have the ability to look this up because my computer happened to die that night, which often happens, and I learned my lesson to back up data. But as a side point, I then went to Kinko's to go look up. You could rent a computer there and to see a literature search whether that was true, if you could just use a different neuromuscular blocker, because I really didn't know at the time. So I then thought, well, so I thought, should we delay the surgery or, and get proper allergy testing or go on? So it's probably about 9:30 at night, and I called the gynec surgeon and asked, would it be okay to work up this anaphylaxis in maybe 4 to 6 weeks, or should we and delay surgery? And she said that it's best to proceed with surgery. Alternatively, she could chemotherapy for 3 months and then resect the cancer, but she said that would not be ideal. So let's ask Dr. Chu, what, before we go on to what then we did, but Dr. Chu, should one delay surgery for an anaphylactic reaction? Can one perhaps do any kind of allergy testing in the 10 days that one waited? Would there be any benefit to that?
That's a good question. I think the really important one is the urgency of the surgery. And in this case, maybe as you present the case, it'll be more information. But in my opinion, because the testing, first of all, takes some time to first get the history, get the details. And if you're going to be doing skin testing, there needs to be a delay of the 4 to 6 weeks because the mast cells need to regranulate. So for the test to be optimum, you want the mast cells to be regranulated. And also because the testing to these agents actually are not very, they're not always very helpful. So an actual culprit may be hard to identify. In my opinion, and I'm glad you checked obviously with the gynec surgeon, delaying the surgery may actually, again, be not the best of care. And if you're able to use the alternative agents, again, safely, that would probably be the best in this case, because you don't want to rush the testing or, do it inappropriately. And again, if it would delay the surgery, that would be not a good outcome either.
So thank you. What would be your anesthetic plan now? So we can't really give a neuromuscular blocker. The surgeon thinks it would be best if we proceed And it's really resting on your shoulders whether you're going to proceed or not. So what will you do for abdominal relaxation for this patient? Anybody?
If you wanted to choose another class of neuromuscular blocker, you could use cystatin. Otherwise, you could just run a opiate infusion such as remifentanil or sufentanil to help.
Or a lot of gas.
So, you know, those are possibilities, but I didn't really want to choose another neuromuscular blocker. And again, this was just for my reading. This is last minute in the middle of the night, essentially, that I can't really decide what to do with that. So I discussed with the surgeon that we could get muscle relaxation with using a thoracic epidural. I said, however, there may be some blood pressure, hypotension with that, and we might need to use some medication like phenylephrine to counteract that. And would you be okay with that? And she agreed with that as long as she could get good and adequate muscle relaxation. So all previously administered medications were then avoided, and Glinda and Gent were given in the pre-op holding area, and I was there ready with an epinephrine stick. And preoperatively, an arterial line was also inserted, and then the thoracic epidural was placed. And she was induced with an inhalational agent, sevoflurane, and she was intubated without a paralytic. So what level of a thoracic epidural, and for sake of time, Dustin's just going to go over the thoracic epidural, some teaching points there.
All right. Depending on, I think you have to mute your mic. Depending on the site of the epidural injection, the dermatomal spread will vary. This is secondary to the fact that high thoracic epidurals have minimal cranial spread, whereas low thoracic epidurals allow for both cranial and caudad spread of the injectate. The etiology of this phenomenon lies in the width of the epidural space. So at C5, the epidural space, the width is approximately 1 millimeter. At T6 is 3 millimeters, and finally at L2 is 6 millimeters. And this concept is demonstrated in the line graph seen on the left here. Starting at a higher thoracic level, the cephalad spread is minimal compared to the caudal spread, whereas with a lower thoracic epidural, the spread evenly distributes cephalad and caudad. So the answer to the question of where the thoracic epidural should be placed for an abdominal procedure is a level that is approximately in the middle of the length of the incision. So for our case, the choice was T6, T7. I also want to take this time to quickly point out that the age and volume also affects the spread. So looking to the right graph, you can compare the market spread in patients over 50 years of age given a 9 cc bolus compared to patients less than 50 years of age given a 5 cc bolus. So the main indication in our case for the use of the thoracic epidural, as Dr. Dolinski mentioned, is for abdominal wall relaxation. I think most people understand that an added benefit of a thoracic epidural for large abdominal cases is excellent pain control afterwards. However, I don't think many residents think of epidurals for the purpose of avoiding neuromuscular blockade drugs altogether. So we do this quite frequently, actually, if we take into consideration how often we use lumbar epidural anesthesia for a primary anesthetic in C-sections. As you can imagine, the timely delivery of a fetus through a phalansteal incision requires absolute. Was quite pleased, reported adequate abdominal wall relaxation throughout the case. There have been reports in the literature of avoiding paralytic agents altogether with the use of an epidural, thoracic epidural. As another example, patients with myasthenia gravis are known to be sensitive to non-depolarizing agents, and use of a thoracic epidural can help the anesthesiologist avoid paralytic agents altogether, as well as having good pain control afterwards to help prevent an exacerbation from pain control. Finally, a note regarding dose. Higher concentrations of bupivacaine or ropivacaine are usually used if the indication is motor blockade, as concentration of local anesthetic usually dictates the depth of the blockade. So in our case, we used 1% ropivacaine. We gave a 5 cc bolus up front and then ran a 7 cc per hour infusion throughout the case. Again, the surgeon reported really good abdominal wall relaxation throughout the case, and actually the abdominal incision was extended. Intraoperatively, they found that this mass was actually a mucinous appendiceal cancer rather than an ovarian cancer, and subsequently a hemicolectomy was performed rather than the planned hysterectomy. The patient was extubated. Postoperatively, the epidural was ran with 0.25% ropivacaine for pain control. She was discharged post-op day 5 as routine. So if we had delayed the surgery for allergy workup, in this case, she would have gotten 3 months of the incorrect chemotherapy, since ovarian cancer was an incorrect presumed diagnosis. Dr. Dolinski, have you used this technique in other surgeries to avoid paralytic agents?
Yes, I have. Yes, I have. I've used it once in a patient that had a cholecystectomy with very severe COPD, bullous emphysema, and essentially the right lung had essentially just 2 alveoli. And that patient, I was a little reluctant to go ahead and just, put him to sleep. The second lady, the request came from the surgeon. The patient also had very severe COPD, and she needed a colostomy reversal. And she had had a prior surgery and a trach and was intubated for 3 weeks, and she really didn't want to go through that again. So I wound up putting a thoracic epidural, and they did abdominal surgery without, and she only got 0.25 milligrams of midazolam, and she slept the entire case. So those are a few cases that I've actually used this before. So why is it important that we, as anesthesiologists, actually refer the patient to an allergist? And it's important because it turns out that we are not that great at deciding what the cause of the culprit is. They've done studies looking at, first of all, on average, it's thought that about 9 medications are received by the patient by the time they develop the anaphylaxis, if you include some of the pre-op holding time as well. And so when anesthesiologists actually state what they think the culprit agent is, they're wrong about 75% of the time. So that is a reason to send the patient to the allergist. And Dr. Chu, what would you like to know from an anesthesiologist when you receive a referral?
Yeah, I think what you have on the slides are really important. So detailed description of the events, including the signs, the symptoms, the copies of the records is very helpful too. And really the timing of when the medications were given and the timing of the reactions are also very important as well. Again, as we talked about, the tryptase level is also important. And then, if there's alternatives, because as you mentioned, Dr. Dolinski, and we had talked about before, unfortunately, the testing, the positive predictive value of the tests are not the greatest because of the type. We usually would want the metabolite, not the whole drug, but all we can do is test with the whole drug, for example, when we're skin testing. So a positive test may be helpful, but a negative test, we're not sure what to make of it. So, we may end up just saying we have to use alternative drugs, but this information would be very, very helpful for us.
So this patient on allergy testing revealed that she was positive to propofol, vecuronium, fentanyl, and cefoxitin. And she was non-reactive. And I did ask if specifically they could, at that time we still had pancuronium, if they could test it for pancuronium, rocuronium, and cisatracurium in case she ever needed to have surgery again. And so it turns out that she was non-reactive to that. And she did have another anaphylactic reaction to a chemotherapeutic agent subsequent to that with vasodilatory shock, and she was intubated and taken to intensive care as well. And then 1 year later, she had a HIPEC procedure, and we were not doing those at Frederick Hospital at the time for cancer recurrence. And they did call me. The lady still had my card, and they called me and they asked what other agents were tested, if so. And so cisatracurium is what they then used. I went back into her chart, and she's actually still alive at age 70 at this point. So the learning points, I think, for us today are that ideally, if we can postpone for an elective surgery for allergy testing, that might be useful. But sometimes we just don't have that luxury, as in this case, delay would have led to incorrect chemotherapy. And bradycardia with hypotension can be a harbinger of impending cardiovascular collapse. It's seen in trauma patients, in anaphylaxis, and also sometimes inferior MIs. Thoracic epidurals sometimes can allow the avoidance, if appropriate for the surgery, avoidance of neuromuscular blockers, and guessing of a causal agent and labeling a patient that having a reaction is not advised, as 70% of the time we're actually wrong with our guess. And an anaphylactic reaction to one neuromuscular blocker is a risk factor for future anaphylaxis to all neuromuscular blockers due to a high degree of cross-reactivity. Consider using this mnemonic PenFast to see if you might be able to give a cephalosporin if they didn't have a severe reaction in the past or weren't treated for anaphylaxis or angioedema. And remember that vancomycin need to be given in a timely fashion because those patients that actually have a penicillin allergy and are given vancomycin have an increased risk of surgical site infections by 50%. And that's primarily because they're not given in a timely fashion. That concludes our conference for today. I would like to thank my co-moderators, Dr. Chu. Thank you very much for participating, and Dr. Hang. And if there are any questions, we can entertain those now.
This is Adam Peperzinski. I do have one question. Do you know what the likelihood is of seeing refractory hypotension as the only sign of an anaphylactic reaction? That is to say, like none of the other typical classical signs like a rash or bronchospasm?
No, it's difficult to say, but in the operating room, we often don't see those other patients are draped. We don't see the rashes. And this particular patient didn't even have any bronchospasm. It seems that patients that have asthma are at increased risk of developing more severe bronchospasm, but it's not always the case either that you see that. So it's obviously a more rare, I think, presentation of anaphylaxis, but in fact, in this patient, they did get an echo to rule out any myocardial issues. They got serial cardiac enzymes to rule out a myocardial infarction. And they even got a spiral CT to exclude a PE. So it wasn't that clear cut at the time of that first surgery that they thought that that was really an anaphylactic reaction. Well, if there are no further questions, do you have a chat box? Do you see any chats? I don't know if anybody chatted. We'll just check that real quick. And if there's no chatting going on.
No chatting.
Okay, then thank you very much for listening to a WebEx presentation. Bye-bye.
Thank you.